Hi, my name is Brendan Kelly, and thank you very much for asking me to speak today. I'm going to talk for a little while about coping with coronavirus, mental health, mental illness, and the COVID-19 pandemic. I realize this is a topic that we hear a lot about, but I'm going to try and summarize some of the research and talk through some of the implications and the things that we can practically do to help. So to begin with, I'm going to talk a little bit about the psychiatric and psychological impact of COVID-19, managing mental health at this time, and then I'll boil it down to 5 tips for mental health. And these are things for ourselves, for me, I need to do them as much as anybody, but also that we can share with patients and families and the like. And I'll finish up with some resources that we can use. So we'll start with the psychiatric or psychological impact of COVID-19. Now, there's been a bit of research about this, and particularly I'll go back to some of the early research which came from China, unsurprisingly, where this is an online survey of about 1,200 people in 194 Chinese cities. And what they did here was they just contacted 1,200 people and asked them about their emotional state, their psychological state. And people rated the impact of the pandemic on their mental health. So these are the percentages of people who reported a moderate to severe impact in terms of overall psychological impact, anxiety symptoms, and depressive symptoms. And what we see is when you contact people in this way, pretty much one person in every 5 will say that the pandemic has had a moderate or severe effect on their mental or psychological well-being. Now, this kind of research clearly has its limits. If you email someone or you telephone someone in some of the surveys and you say, has the pandemic caused you psychological suffering? A great number of people are going to say, yes, it has. The real discriminatory power lies in distinguishing what is and is not more than one would expect, or what is or is not disabling, or what is or is not clinically significant. So that's the challenge with these studies. But there is a continuity across the research that around 1 person in 5 will report an effect that is over and above what they might expect or what might be deemed to be a reasonable impact of the pandemic. If we look at some of the Irish research here, the Maynooth University and the psychology department in Trinity did a survey, again quite early on in the pandemic, looking at 1,000 people from a panel that they surveyed, asking about the clinically meaningful mental health problems. And again, you can see that for depression, anxiety, and PTSD, around 1 person in every 5 reports a clinically meaningful psychological problem above and beyond what they would expect. There's a good lot of overlap there between those with depression and those with anxiety. So this is population well-being, population psychological health, as opposed to mental illness. But the surveys are nonetheless interesting as indices. So who's most at risk? Looking at the research as a whole, among the general public, the risk factors for poorer mental health outcomes or psychological health are female gender, being younger, and pre-existing poor health. And of course, we keep hearing about pre-existing conditions being a risk factor for COVID-19, particularly for bad outcomes and more difficult hospital courses. Younger people do tend to cope less well with this than older people. Now, people over the age of 70 are in a somewhat different category, but broadly speaking, it's younger people. And female gender is an interesting risk factor for less psychological health at this time. And it is, of course, consistent with the finding that depression is diagnosed twice as commonly in women as it is in men. So what about population mental health then? What should we do for the country as a whole, if anything? This is obviously quite a tricky one. There was an ocean of research following 9/11, and it's very clear that for the general population who are not exposed to specific personal trauma, people tend to cope best on their own with their families and their friends and their communities. But they need to know the door is open if further help is needed. And that's very much the case for most people in the categories that I'm talking about here, that we do need to provide sort of the tools for people to help themselves and to support each other, but there's not much point in declaring that 1/5 of the population is mentally ill. It's not accurate, it doesn't get anybody anywhere, and it fails to acknowledge the true nature of the suffering and how it can be relieved. The Central Statistics Office has some interesting figures on this too. They do a really good survey of thousands of people, and they ask, you know, do you feel depressed some, most, or all of the time? And in 2018, you can see the numbers there. 13% of people, more females than males, reported to the CSO survey they felt depressed some, most, or all of the time. 2020, this is in June of this year, in the midst of the pandemic, these numbers have predictably gone up. 26% of men, 39% of women, and overall 1 in 3 people saying they're feeling depressed most or all of the time. So what does this translate into? Is this mental illness? Is this unhappiness and frustration at the pandemic, at the restrictions and all of this? Well, the College of Psychiatrists of Ireland did a really good survey that's online, and they found toward the start of this that 64% of psychiatrists reported increased self-harm or suicidal ideation at the start of the pandemic. Now, what does this mean particularly? Well, one of the other ways of looking at this is to look at the rates of presentation to hospitals with deliberate self-harm, because that survey result from the College of Psychiatrists includes suicidal ideation. And we know from the CDC in the US that in the US, the CDC surveys have found that 11% of Americans have at some point thought life is not worth living during the course of this pandemic. So suicidal ideation is quite a different thing to acts of self-harm. And when we look, here's a report from the Irish Examiner on the 11th of September, and the sort of headline from this is that the early data indicates no rise in suicide during early lockdown. And in fact, hospital presentations with deliberate self-harm fell by 25% in the opening months of the pandemic earlier in 2020. Now, that's not quite what it seems, because hospital presentations with everything fell between 25 and 30% during the opening months of the pandemic. But what it does suggest is that presentations with deliberate self-harm have not differed from general hospital presentations during the early months of the pandemic. And what about completed suicide? Has that changed? Well, it's too early to say because figures are slow to come in. But this article did include a rather interesting comment from Mary Flanagan, president of the Coroners Society, who said that in her experience in Cavan and South Monaghan, she did not feel there was a suicide epidemic during the pandemic, and that the numbers appear stable for the past 6 months. And this was a report in the September Irish Examiner. So in terms of suicide, it's not clear. The history of suicide statistics suggests that there mightn't be a huge change. Now, most of you will know this already, but I will go through it here now. This is the world rate of suicide. You can see here 1990 is on one side at the bottom and 2017 on the other. And this is the rate of suicide, the number of suicides per 100,000 population in the world. The middle line, the red one, is everyone. The upper green line is males and the blue one is females. And if you look at the red line, what you see here is in 1990, the rate of suicide around the world was 15 per 100,000 population per year. And by 2017, that had fallen to just under 10 per 100,000 population per year. So in other words, the rate of suicide around the world is falling very dramatically. It fell by 1/3 between 1990 and 2017. And you can see it's falling in males and falling in females. The rate in males is higher than females, but suicide in the decades leading up to this pandemic has been steadily falling. Now, a couple of things bear mentioning here with these figures. It's not quite even. In some countries, it's falling quicker than others. And those figures include one country where, one big country, where suicide hasn't fallen by a third, but has increased by a third in those years. And that country is the United States. It has moved contrary to the global trend on suicide. But even including the US, globally, it has fallen by a third between 1990 and 2017. That fall is also apparent in Ireland. So suicide has been on the way down, and that's the context in which we need to consider any increase or any fall or any stability in rates during the pandemic. The other important point to make about suicide is to take this graph back further and look at it over the course of the last century. Here's a suicide rate in the US only. The last slide was the world. This is the US. 1907 up to 2017. And watch, the vertical axis here does not go down to 0. It only goes down to 10. But it's the same number otherwise, the rate per 100,000 people. And if you follow that red line, you'll see that the big fall there happened during there was a fall during World War I. That's the first big dip. It went up again. It fell again during World War II. It went up again, but it never went up as high as it had been prior to the war. And there you can see at the end that increase I mentioned in the US at the very end that is contrary to the global trend. So world wars produced diminution in suicide, partly because a lot of the at-risk people were at war, young men, partly because roles changed very dramatically, particularly for women who were at home and had greater, or at home as in their home countries, not serving in the army, but had greater responsibilities in workplaces and factories, and that seems to have helped. But suicide fell during the two world wars. Another possible reason could be community cohesiveness, which was increased. And it will be very interesting to see when we get suicide statistics for now, just how it happened. Now, I should emphasize, of course, that even one suicide is one suicide too many. And when I say that the rate has fallen by a third, that is by no means enough. We need to work much, much harder, but it does prove that suicide rates can fall. And we should tread carefully during the pandemic to make sure that we provide the supports to those who need them and try and continue that trend. So that's population mental health. That's everybody. I'm going to focus now for a quick minute on healthcare workers. And again, if we go back to some of the early research in China, this is a study of about 1,200 healthcare workers, which found that almost 3/4 of healthcare workers expressed clinically meaningful levels of distress, 50% depression, 40% anxiety. If you look at the totality of studies about this, approximately 40%, that's about double the population rate of healthcare workers report clinically meaningful psychological problems as a result of the pandemic. The risk factors, again, female gender, working as a nurse as opposed to another kind of healthcare professional, a lot of frontline time, and then working in areas like Wuhan. So that's healthcare workers, a rate of clinically significant psychological distress of about 40%, double the population rate. And of course, there are all these additional issues that are of concern to healthcare workers about, the availability of PPE in certain countries, tensions about rosters, shall we say, financial issues, and of course the worries about bringing COVID home to your family, all of which are relevant to varying degrees here in Ireland too. Now, I have to say there is a very good editorial about this available, free of charge, of course, in the Irish Medical Journal, written by our colleagues who you see there on the screen. And also there's a whole series of papers in the excellent Irish Journal of Psychological Medicine special issue on COVID-19. Again, this is the College of Psychiatrists of Ireland Journal. It's available online, and all papers are open access, free to access. So everything I've spoken about so far has been about the effect of COVID-19 on patterns of mental illness, mental distress. A lot of attention has been devoted to this. Far less attention has been devoted to the impact of mental illness on the pattern of COVID-19. And that's one of the things I really want to highlight today, particularly in the context of a paper that just appeared in the journal World Psychiatry, which is, again, World Psychiatry is a It's free to access online. And this is a really interesting and important paper about the risk of COVID-19 infection, hospitalization, and mortality in people with mental disorders. And these researchers, it's a US study, they looked at a huge database, millions of people in the US, accounting for a coverage of 20% of the entire, 20% of the entire population of the US. Their medical records were analyzed for this study. And to put it in a nutshell, I've highlighted in red there, patients with a recent diagnosis of a mental disorder had increased risk of COVID-19 infection. For depression, the odds ratio was 7.6, and for schizophrenia, 7.4. Those of you who like statistics will see those figures have really tight confidence intervals. So these are very reliable findings. What this means is somebody with a recent diagnosis of depression or schizophrenia, the odds of them getting infected with COVID-19 are more than 7 times the odds of someone without such a mental illness getting infected with COVID-19. And this analysis controlled for age, for gender, obesity, and pre-existing medical conditions. So even when you take the distribution of those things into account, people with these diagnoses have more than 7 times the odds of being infected with COVID-19. Similar odds ratios apply to other conditions, though not quite as high. So the odds for someone with ADHD, for example, their odds of being infected with COVID-19 are 5.8. It's almost a 6-fold increase in the odds of COVID-19 if you have ADHD. And for bipolar disorder, it's 5.7. Again, all of that is after controlling for age, gender, obesity, and pre-existing conditions. There's also an increased risk with these diagnoses of requiring hospitalization for COVID-19 and an increased risk of dying from the infection. So what we've neglected in a lot of our discussions to date is the effect of pre-existing mental illness on the distribution, the pattern, and the impact of COVID-19. And this is a headline finding, and it is a rather important one. And of course, it speaks to what we already know, which is that people with mental illness have difficulty accessing physical health care and difficulty accessing public health advice. So difficulty accessing physical health care, we know that men with schizophrenia die 15 years earlier than men without, women with schizophrenia 12 years earlier than women without. And for the public health advice, we know that people with enduring mental illness have very high rates of smoking, and public health advice to stop smoking doesn't seem to impact as it should. That's one of the effects we're seeing with the numbers I've got on your screen there. We live in an era when adhering to public health advice is vital, and it would appear public health advice about COVID-19 is having just about the same amount of impact that public health advice about smoking has among many people with mental illness. And that's something, it's a role obviously for us as community mental health teams to try and get messages out there about these things to the people who attend our services. So that's a little talk about the psychiatric impact of COVID-19, and if you like, the impact of mental illness on the distribution of COVID-19, which is a neglected topic. Managing mental health during COVID-19. Well, I am, as is almost traditional now, going to draw attention to this resource. I wrote a short book about this at the start of the pandemic called Coping with Coronavirus. We wanted to make this book free, but it turns out it's not possible. So the ebook costs just €1. Royalties go to the Red Cross, and you can just download it onto a phone or anything from Amazon or where have you. And they're also printed, or if you can tolerate the sound of my voice, which I appreciate many of you can't, there is an audiobook with me ranting my way through it. The book focuses on practical strategies to try and manage mental health. This is aimed at the 20% of the population who are experiencing more distress than they should, rather than, if you like, people with severe mental illness. This is about managing well-being. And I've broken it down into managing knowledge, how we think about things, managing our feelings. Behavior is very, very important. Actions. That point number 4 is doing, and not, as my daughter tells me, doing. It is doing and things we can do to help. And finally, being. This tendency that we have to think about this pandemic not so much as a big public health problem needing a big solution, but our tendency to think about it as an existential crisis for humanity, which it might well be. but there's absolutely no point getting too caught up in that when what we need to be doing is wearing masks, washing our hands, and supporting our patients to follow the healthcare advice. Rather than talking you through the entire book, what I'm going to do today, you will be very relieved to know, is I have reduced this down to just 5 key tips that I think are important for us and for our patients. The first thing is, this talk about the new normal is not a very helpful phrase. There is nothing, and there never will be anything normal about this. This is a tough time and a strange time, and we need to give ourselves and each other's more permission to be upset and be distressed by it. It's understandable, and we need to give a bit of airtime to that. We cannot carry the weight of a global pandemic on our shoulders every minute of every day, as many people are trying to do. We should limit our media intake about the global pandemic to once or twice a day, 15 minutes maximum. There's no point in carrying this with us every minute of every day, and a lot of people need to take that advice. Obviously, routine is very important, things like diet and exercise and staying in touch as best as possible. We tend to neglect behavior at times like this. We spend all our time thinking and analyzing statistics, scrolling through social media, looking for the most unlikely possible theories, and then we dismiss them, but they still have an emotional impact. Getting out of our heads is so important. We're hypercognitive. We live in a hypercognitive era. Our brains, with 86 billion neurons and trillions of synapses, are vastly too complex for us to understand or to deal with. So we need to get out of our brains as much as we can. Going outside is a really good way to do this. Another way is getting into something, getting into a state of flow or absorption in any activity that you like. Now, traditionally, we talk about mindfulness and meditation, and that's all very good, but some people find that just irritating, if I'm honest. A lot of activity achieves mindfulness, but just without the lingo. So when you talk to people who go running, for example, they often say when they're running, they've no thoughts, there's just the movement, the motion. And that is, in fact, a state of mindfulness and absorption. The same applies to gardening, especially for older adults who mightn't be able to go out that far. Knitting is also very good. And of course, the mindfulness and the meditation. But a lot of people find that meditation and mindfulness evokes these kinds of unrealistic images of, states of enlightenment and levitation that just will never happen. Schools have some very interesting mindfulness programs, but let's not forget the other things that we naturally do that bring us to this state of absorption. I've given the example of running, and also a rather updated and modern example of knitting, which can be a uniquely absorbing activity for people who are into it. So what I really wanted to talk about today was the psychiatric impact of COVID. The pandemic appears to have given around 1 person in every 5 psychological distress that they regard as too much or difficulty coping with. For healthcare workers, that's around 40%. It's around double that. So we need to be mindful of how we support our colleagues, how we support ourselves, our families, and so forth. Let's not forget the impact of pre-existing mental illness on COVID, and the patients that many of us see with schizophrenia and bipolar disorder. They do need extra public health advice and encouragement to follow it, as we know is the case with stop smoking advice already. In terms of managing our mental health, we do need to devote a little bit of time to that, try and avoid too much media exposure, engage in some good behaviors, particularly becoming absorbed in activities that we like. There's some really good resources from the HSE. The CDC in the US, their website is really good, and they have a workbook talking with children about coronavirus disease. That is really good for people who struggle to know what to say to parents who have children or what to say to children. Inclusion Ireland and Cheeverstown have some good online resources regarding intellectual disability, and Nursing Homes Ireland and Parents Plus as well. Obviously, I'm not going to finish without giving a further mention to coping with coronavirus, which you can download from Amazon and so forth. And to finish with the final flourish, some of you may be familiar with this figure, Professor Anthony Clare. This has absolutely nothing to do with COVID, I'm afraid, but myself and Maurice Houston have just co-written a biography which is available for those of you who are keen. As I say, the Coping with Coronavirus book, just €1, proceeds to the Red across. So look, thank you very much for speaking to me today. I believe there will be a live questions and answers a little bit later on, but thank you for your attention, and hopefully we can talk later. Goodbye.